Hello, I am Steve Amman, cardiologist at Mayo Clinic in Rochester, Minnesota, and the chair of the 2024 HCM guidelines. We're going to talk to you today about some of the changes, but I'd like to welcome Dr. Carolyn Ho. And Carolyn, do you want to introduce yourself briefly?
Sure. Thanks, Steve. I'm Carolyn Ho. I'm at Brigham and Women's Hospital. I'm the medical director of the Cardiovascular Genetics Center, and I had the distinct honor of being the vice chair for this update in our guidelines.
Yeah, this is really exciting. The HCM guidelines are the first guideline to test a new process that AHA and ACC are trying to make the guidelines more nimble, where based on simply any new data that might change recommendations, they want to have a process that makes these more of a living document. And in our case, it was the introduction of mavacamten, the first cardiac myosin inhibitor, and randomized controlled trials around that allowed us to convince the committee that oversees the guidelines to say, let's give this new updating process a try. I think because we have a limited time today, I think we'll limit our things to maybe the two biggest changes in the guidelines, that being the introduction of mavacamten, and the second one being some evolution in the guidance we give our patients regarding exercise and activity levels. Carolyn, you've been part of the randomized controlled trials and the basic science and understanding the underpinnings of HCM for long enough. So do you want to talk to us a bit about mavacamten and where that fits now in our management of patients with obstructive HCM?
Yeah, sure. It's been a really exciting time to be involved with hypertrophic cardiomyopathy because for the first time in the decades and decades that this condition has been clinically described, we actually have properly powered, appropriately run, placebo-controlled randomized clinical trials. So we can finally get to the level of evidence with the R next to it for hypertrophic cardiomyopathy for randomized trials. And the first on the scene were this novel class of cardiac myosin inhibitors, of which mavacamten was the first in class. And it was a phase 3 Explorer trial testing mavacamten versus placebo in patients with symptomatic obstructive HCM that really has led the way to this guideline update. The trial was completed and published in 2022 and showed that mavacamten, compared to placebo, was able to improve the feel and function primary endpoint of the trial. So patients taking mavacamten were more likely to have an increase in peak VO2 and NYHA class, or a more substantial increase in peak VO2 compared to individuals that were randomized to placebo. And so this led the way to FDA approval of mavacamten in April of 2022.
Yeah, that's right. And so now we have to figure out where that fits into our rubric of caring for patients with obstructive HCM. Historically, we have always used the non-vasodilating beta blockers and the non-dihydropyridine class calcium channel blockers as line 1 and line 1A of therapies. So why don't you describe where mavacamten now fits in this progression from basic medical therapy to invasive procedures potentially?
Yeah, absolutely. So it's another tool in the toolbox for us on the medication side for the medical management of hypertrophic cardiomyopathy. So the first line treatment remains beta blockers or non-dihydropyridine calcium channel blockers, so verapamil or diltiazem. If you have a patient with obstructive HCM who's symptomatic, then we would try first one of those agents. If those agents are not adequately effective in improving symptoms and quality of life, or if they're not well tolerated, previously we would think about adding on disopyramide and moving on to invasive septal reduction therapy. But now what we're able to do is if our first line therapies, the beta blockers or calcium channel blockers, are not adequately effective, we're able to think about using mavacamten as an additional medical option before moving to septal reduction therapy, or as an alternative to moving to septal reduction therapy.
Yeah, that's right. And while it's not inherent to our guidelines, I guess it's important for those maybe watching this to understand that there are some logistics involved with using mavacamten. The way it was approved by the FDA was there's a pretty intense risk evaluation and mitigation strategy. Such that, and this is based on some of the metabolic pathways, the CYP pathways that mavacamten impacts, and the finding that somewhere between 5 and 10% of patients in the mavacamten trials showed that it was such a potent negative inotrope that it dropped the ejection fraction to less than 50%. We now have this safety surveillance program. And what that means is that patients have to get their medications through a specialty pharmacy. It can only get the medications essentially a month at a time, and they have to check in with their provider who is managing their prescription regarding any new medication starts they have, any change in their symptoms. And they also have to get an echocardiogram each month for the first 3 months they're on it, and every 3 months for as long as they're on it, and also if they have dose changes, which are also pre-specified based on symptoms and gradients and those types of things. There are some logistic challenges, but I agree with you. It's a very important tool that we now have for our patients and an option for many of them.
Yeah, absolutely.
Do you ever see patients going directly from, gosh, I'm symptomatic and I got diagnosed with HCM directly to a cardiac myosin inhibitor? Or do you still think it's important for them to give a trial of the older medications?
Yeah. So that's a great question. I think that this is going to be a work in progress, and that what we say today is probably not going to be the same as what we say in 6 or 12 months. And so right now, mavacamten is only approved as a second line. Theoretically, patients are supposed to have been trialed on a calcium channel blocker or a beta blocker first, and have failed those, again, either because of not tolerating those standard treatments or not having adequate relief. From a practical standpoint, we still start with that, because like you just explained, prescribing mavacamten is not like prescribing a metoprolol. You don't just call it into or enter the order into Epic and have it show up in Express Scripts or at CVS, and the patient picks it up and they're on their way. There's a lot of logistics that have to be sorted before a patient has access to mavacamten, and a lot of logistics that have to be met to maintain access. And that's fair that there are these training wheels on these drugs. They are myosin inhibitors. They do impact contractility. There's not a lot of experience with them yet. We're gaining more and more every day. There haven't been dramatic safety signals, but still important to make sure that we're dispensing this safely and responsibly. So because of those additional logistical hurdles, definitely trying metoprolol or verapamil or ditazem first is much easier than going straight to mavacamten. There is the MAPLE trial that's ongoing. So it's a trial of metoprolol versus aficamten. And I think that will be really instrumental in helping us understand how cardiac myosin inhibitors could be rolled out as first-line therapy. And aficamten, of course, is the second-in-class cardiac myosin inhibitor, which has just finished its phase 3 trial successfully, the SEQUOIA trial.
I guess we should be more explicit on where we've defined in the guidelines where mavacamten now fits. And if we look at figure 4 in the guideline document, first of all, patients have to have symptoms. It's important to recognize that asymptomatic and active patients with HCM do not require medical therapy. But if they have obstructive HCM and symptoms, then as Carolyn just said, we start them on either one or the other, beta blocker or calcium channel blocker groups that she described. And if either that is not effective or it adds side effects that are not tolerable, then the way the guidelines are written, mavacamten and disopyramide and septal reduction therapies are all options for those patients at that next level. If they're failed first-line therapy, then we've really said patients should hear about all of the advanced or next tier options for them in our guidelines. And obviously in clinical practice, there's going to be nuances to patients that might make one of them more attractive than others, but we've not specified that you have to fail multiple classes of medications to get to SRT or have to fail another drug before you get to mavacamten. They really are considered, if you fail that first line therapy, you are eligible for any of the advanced therapies.
And I think that's a great point that you bring up, Steve, in terms of the patient involvement in this decision making, because not one size fits all for any aspect of hypertrophic cardiomyopathy, and patient preference and choice is really important in making sure that we have the discussions with our patients to let them know what all the options are and help them come up with a strategy that best fits them specifically.
I think that's right. I've had both. I've had patients who absolutely want to do everything they possibly can to avoid having any sort of procedure done to them. And I have other patients who want to do everything they can to avoid taking a medication. And so it's really important that we talk to our patients and understand which option fits their goals and the rest of their medical history best.
Yeah, absolutely.
All right, so maybe we should now shift to maybe one of the even more definitely more controversial and more nuanced areas in the management of patients with HCM, and that is what we tell our patients about activity levels. And we have seen an evolution in our recommendations from the 2020 guidelines to the 2024 guidelines. And I think maybe to start with, I'm going to separate out elite competitive athletes first. And let's just talk about the non-athlete, the person who's not trying to make their career or their college based on their sports, but the average HCM patient that comes to see us. What have we learned about exercise activity levels, and what are the recommendations in the guidelines now?
Yeah. So another great breakthrough of sorts for hypertrophic cardiomyopathy was really studying the impact of exercise on quality of life and other outcomes, and specifically arrhythmic outcomes in patients with hypertrophic cardiomyopathy. There's long been worry about the potential impact of exercise in triggering malignant cardiac arrhythmias, and accompanied with varying degrees of caution about allowing patients to participate in sports. But again, setting aside the competitive sports, I think that what we've learned over recent years from both the LIVE HCM trial and other studies has been that exercise is good. Pretty much everybody and patients with HCM enjoy the same benefits from a physical standpoint, from an emotional well-being standpoint as other people. And so we're really, again, reminded and encouraged to encourage our patients to engage in regular, moderate intensity physical activity.
Yeah, that's right. In the prior guidelines, now we've made this a class 2A recommendation, meaning it is reasonable for patients with HCM to participate in the same level of physical activity that is essentially recommended for the rest of us. We still have some reservation about high intensity training, high intensity intervals, because we just haven't had robust data that completely answers that question yet.
Yeah, and I think that it's important to perhaps make those distinctions. Remember that these are nuances and subtleties that, again, not everybody is the same, and there's no one-size-fits-all approach. Some people may consider themselves elite athletes, but we really want to be honest about what we consider to be an elite athlete, where the training is of the rigor and the caliber where you really aren't allowed to spell yourself out or take a break if things get a little bit uncomfortable. So these are the people that really are performing at the highest level of participation. And those people where, scholarships or careers are being questioned, that's a great opportunity to take advantage of expertise that's around referring patients to HCM specialty centers, particularly those with expertise in managing athletes, would be beneficial all around.
Yeah, that's right. I have often said to people, one of the things that makes elite level athletes successful is that they are able to maintain their fine motor skills while ignoring signals from their body to stop. And that's exactly what we don't want our patients with HCM to do, is ignore what their body is telling them to do. And so that's in part why we have kept the kind of separated out exercise activity, healthy lifestyle recommendations from the consideration for whether an individual wants to consider sports. We think it can be considered, and we specifically have a class 3 now recommendation said there's no dogmatic exclusion just because you have the diagnosis. But we think it does take more of that discussion between the individual athlete, their goals, their cardiologist, who should know both HCM and sports cardiology, as part of that discussion to say, is this something you want to do?
Right. Yeah, it's important to have all the stakeholders, including the teams and the institutions, at the table.
Yeah, that's right. As we're wrapping up here, I think it's worth pointing out another section that looks like it may have changed, but really hasn't changed too much, and that is in the sudden cardiac death risk assessment area. Previously, we had lumped adults and children together. We've separated out adults from adolescents and children, mostly based on word count limits and the rubric we use for developing the guideline document. So there's not a lot of change in the content other than maybe the addition of pediatric risk calculators for shared decision making, but it looks like a change when in reality it's a confirmation within the guideline document. Carolyn, is there anything else that you would like to highlight that you think are important changes or evolutions in the guidelines?
No, I think that you hit all the high points in terms of the major issues that people are going to want to know about. The introduction of our first disease specific, robustly randomized, clinically trial tested agent, mavacamten, and its role in symptomatic obstructive HCM. The encouragement of people with HCM to embark on healthy exercise, and reminding everybody that children are not just small adults. There are separate sections, again, mostly from a logistical standpoint, but also just to separate the care of pediatric patients with adults. So I think that those are the highlights. There's a lot to look forward to. It's a really exciting time to be involved in hypertrophic cardiomyopathy. More new therapies are on the horizon, and having this ability to update our guidelines more in real time rather than sometimes the decade long interval between versions is going to be, I think, really valuable for providers and for patients alike.
Yeah, that's right. And you did touch on something else, which is really important, is there are a number of new randomized controlled trials on drugs specifically targeting non-obstructive HCM, which are going to be a very important next iteration of therapies for patients with HCM.
Right. And also trials that are getting started enrolling pediatrics, patients, adolescents as a first pass, patients between 12 and 18 years of age for our cardiac myosin inhibitors for symptomatic obstructive HCM. So a lot going on in this space.
Yes. Thank you so much for joining me for today to help share the highlights of the new guideline document. And I hope everyone who's listening and watching found this to be a valuable discussion.
Thank you also to the ACC and AHA for commissioning these guidelines and for allowing for us to be the first pilot for a more real-time update. And most importantly, I want to thank the rest of the writing committee. It really takes an army of people to provide all the content, all the double checking, and the peer review. So for the writing committee, the reviewers, and all the staff at ACC and AHA, a huge thanks for that, for them as well.
Absolutely. Thank you all.